Welcome everybody. Thanks for joining us. It's really nice to see all your faces here in 2025. I hope you're all staying relatively warm with the weather we've all been having in the last week or so. For those of you that don't know me, John Kibali, Project Director for the Social, Behavioral, and Economic COVID Coordinating Center. And we really appreciate you guys joining us for today's presentation, which is going to be findings from SBE COVID Coordinating Center pilot project grants. We're actually going to be hearing from three pilot grant recipients today: Dr. Julie Keller, Dr. Zhenlong Li, and Dr. Rob Smith. I'd like to introduce the first of our three speakers, Dr. Julie Keller. Dr. Julie Keller is an associate professor of sociology and the director of the Social Science Institute for Research, Education, and Policy at the University of Rhode Island. She'll be presenting on investigating vaccine hesitancy and factors that build vaccine confidence among refugees in Rhode Island. Julie, I will hand things over to you.
Thank you. Thanks so much, John, and thanks everybody for attending today. I'm just going to attempt to share my screen here. All right, so thanks everybody. Thanks for the invitation. Our project does focus on vaccine hesitancy and vaccine confidence among refugees in Rhode Island. We have a really wonderful interdisciplinary team of folks from University of Rhode Island, including our PhD student in nursing, and she has really taken the lead on our qualitative analysis for this project. We have Erica Lieberman, who is a nurse practitioner on the project, and an undergraduate student working with her as well, and Steve Cohen and Molly Graney in health studies. So this project really came out of our connection and a pre-existing connection with a community-based organization. And they had concerns. This was a refugee-serving organization. I had been working with them on an unrelated project, and they had some concerns about vaccine hesitancy among their clients. And so that was really the starting point for a collaboration with them. Our study aims include investigating COVID-19 related knowledge, attitudes, and beliefs among refugees, identify perceived barriers to COVID-19 vaccination in that population, looking at health literacy, looking at identifying sources of accurate and inaccurate information about COVID-19 vaccines, and then from there trying to identify factors associated with increased vaccine confidence and decreased vaccine hesitancy. We are using this community-engaged approach, since this study really did start with the CBO priorities, as I mentioned. We have been using a sequential mixed methods approach to do this work. So we have two different phases that inform one another, starting with the qual phase and then followed by the quantitative phase. We also decided to put together a community advisory board for this pilot study. So we selected staff from various community-based organizations working with refugees in the state of Rhode Island to be part of this CAB. We've had 3 meetings so far, and we do have one final meeting planned. And here is a overview of our methods for each phase. We conducted 8 focus group discussions with refugees, as well as 8 interviews with healthcare professionals who treat refugee patients. And then phase 2, our quantitative phase, consisted of a survey of 111 refugees from various regions of the world, and this was a separate sample from the focus group discussions. So our question areas within the focus groups included just general COVID-19 experience and knowledge among refugees, their beliefs and attitudes about the COVID-19 vaccine, where they get their health information, and then we liked to conclude each session with their ideas for change. On the provider side, as far as working with refugee patients, healthcare providers were asked about any potential barriers to care and vaccination in that population, organizational support, any sorts of system-level barriers that they wanted to identify in terms of healthcare access and vaccination among that population, and then health literacy challenges. Our survey domains are depicted here, and we included an adapted COVID-19 vaccine hesitancy scale. It did consist of a larger number of items, and we had to narrow that down to 5 at the end of the day, just because of the length of the survey. We included a multi-part question about trust, a trust scale question, as well as questions on health literacy, our brief health literacy screening tool, self-rated health, healthcare access questions, demographics, and then a couple of questions on their social media use. Our phase 1 analysis, we did use deduce for our analysis there with the qual data, following the Braun and Clark thematic analysis approach. Our phase 2 analysis with our quant data, this is our plan. We've really just scratched the surface on the quant data analysis. Steve Cohen is leading that part of it. And so what I'll be reporting here is where we are now, but we have a lot more planned. So just jumping into some preliminary analysis. So looking at our focus group data, and again, we conducted 8 focus groups. This is the breakdown by a region where those refugees were coming from, with a total sample size on the focus group end of 60. Our average age was 44.4 years old, mostly women in our focus group sample. You can see the breakdown in education here, with quite a few refugees with some high school or less, compared to those with high school graduation or more. The majority of refugees were vaccinated. And we'll talk about this a bit, but we had a number of such a high percentage of recent arrivals in our sample. And COVID-19 vaccination is strongly suggested prior to arrival in the US as a way to kind of fast track their children to enter the educational system, and for a number of other reasons. So although it's not required, it was very strongly encouraged overseas. And again, that's the breakdown by region and some information about age, just a little bit more detail there with the age breakdown, marital status breakdown, and again, the gender. And then in terms of country of birth, just to get a little bit more specific, we did have a large percentage of folks coming from the DRC, and then Guatemala and Syria. And that really made sense given the organizations that we were working with and the clients that they were serving. You can see the breakdown as I was discussing with the time in the US, and this just reflects how recent these arrivals really were. Just looking at that 1 month or less, 1 to 3 months, and 3 to 6 months, and seeing what a large proportion of the sample that those 3 categories make up really does say something about just how recent this group was in general. So our themes, we're going to report today on 4 different themes, our team. We have additional data still to analyze on the focus group side, but for right now, we have these 4 themes that we've compiled in a paper that we have submitted, and we're waiting on word for that from the journal. But our 4 themes here are the COVID-19 pandemic was a difficult, stressful, and fear-inducing experience. Feelings of mistrust and beliefs of malicious intent surrounding the virus and vaccine. Theme 3, health concerns, and then theme 4, that the vaccine was protective and beneficial. So I'll just give you the quick version of this. It's always hard with qual data to present this quickly and efficiently. So participants across all 3 regions identified the impact of COVID to be overall difficult, stressful, and fear-inducing experience in a variety of different ways. Sub-themes included the sense of loss, fear of the virus, fear of the unknown. Religious symbolism came up as well in this discussion across focus groups, across different regions. Those individuals expressed hearing beliefs from their community that it represented, that the virus was the mark of the beast, for example, or it meant that the end of the world was coming. This was described as just a very scary time, understandably, not knowing what was happening. And this is, I'm just showing your exemplar quotes at the bottom here for you to review, that coincide with this theme and these particular sub-themes here. The second theme, across all three regions, participants identified feelings of mistrust or beliefs of malicious intent surrounding the virus and vaccine. Sub-themes were, beliefs that the virus was not legitimate or fake, or that the vaccine had racist underpinnings. And another sub-theme was viewing the vaccine as a business rather than a tool to protect public health. And you can see our exemplar quote here coming from one individual in our Middle East focus group number 6. And, these specific beliefs about racist underpinnings that really came out in particular from focus groups with African refugees, and this individual describing, the sense of feeling as though they're guinea pigs is, reflecting this very deep concern about the racist underpinnings of the virus and the vaccine. Theme 3 was just general health concerns, and this was tough to kind of parse out, but we identified sub-themes here: perceived limited protection, concerns about quick development of the vaccine, fear of negative side effects and long-term effects. And this individual here, explaining, I think it's useless to take the vaccine because we still have the disease everywhere. And then just jumping to theme 4 here, by contrast, we did see this theme running throughout groups from some folks that the vaccine was protective and beneficial. And so this was something that did come up even at the same time that we had a lot of expressions of mistrust and doubt about the vaccine. Provider interview data from those 8 interviews, we're still analyzing those. And something that stood out to us at this point, looking at the data, it's that providers weren't really distinguishing between refugee patients versus other immigrant patients. And in this study, we're really trying to understand, is there something, unique about the perspectives, the experiences of refugees when it comes to vaccination, and in particular, COVID-19 vaccination. And that was kind of tough to parse out. But what was clear is that there's very limited time that providers have with patients. And if there is interpretation required, there's even more minimal time. It's much more of a one-directional kind of interaction and not a lot of questions coming from the patient due to lack of time. We have just really quick preliminary data on the survey end. And Megan, let me know how many minutes I have left right now, because I can't see the chat.
You have about 3.
Oh, great. Okay. Yay. So our phase 1 qual data and the CAB definitely informed the survey design and that survey length. So we had tested, just informally tested the survey with some staff at one of our CBOs, and they just kept saying, it's too long. It's just too long. We can't expect participants to take this survey as it is. So we had to, really narrow that down and shorten, I know, as reasonably as we could. We had 3 different organizations assisting us. We had the survey translated into English, Spanish, French, Swahili, and Arabic. And then we trained interpreters. They were IRB approved, and I can talk about any of these logistical aspects if people want. And we have 111 surveys that were completed. This is just some descriptive statistical data, just scratching the surface here on the quant side. The COVID-19 vaccine is important for myself, my family, and other people of my community. So this was part of our COVID-19 vaccine hesitancy scale. And this just gives you a sense, a quick kind of snapshot about on responses to these questions in that scale. Getting the COVID-19 vaccine is the best way to protect myself and my loved ones from the coronavirus. So again, mostly agree or strongly agree. The COVID-19 vaccine is effective. Again, quite a few people signaling that they agree with that or strongly agree with that statement. And then we move into a bit more complexity here. The COVID-19 vaccine carries more risks than older vaccines. a number of people choosing neither agree nor disagree, and then just more even distributions here, with strongly disagree, disagree, and agree. And so we're still trying to understand, what exactly that means, in light of their previous responses to the other items on the scale. I'm deeply concerned about serious negative effects of the COVID-19 vaccine. Similarly, some complexity here to dig into. Confidence, what would make you more confident in accepting the latest COVID-19 booster? Most folks were marking that, if their doctor recommended it, that they'd be much more likely to accept that as a comparison to other sources. There's more to dig into there for sure. And just looking at health literacy really briefly from what we're able to ascertain, we have quite a few folks with low levels of health literacy in our sample on the survey. And then Steve, my collaborator on the team, who's analyzing the survey data, this is very exploratory logistic regressions looking at health literacy on length of time in the US, on sex, on age, and language of survey. So this just kind of starts the conversation here on what may end up looking relevant just in looking at our examination of health literacy. We see some interesting measures to dig into here. Implications, of course, we have to look at mistrust. Mistrust of the government is in particular an important topic here. We need culturally appropriate, effective interventions to really tackle this vaccine hesitancy that we're seeing among refugees and in such a diverse population. We'll be continuing our data analysis. We'll be continuing to share our results with stakeholders. And we're hoping to apply for more funding to perhaps extend the study to look at all of New England. And we're very grateful to our funder and our community partners. Thanks, everyone.
Wow, thank you so much, Dr. Keller, for that. That was a lot to fit into to 15 minutes. So tip my hat to you on doing that so successfully, but really exciting to see some results there. So with that, we're going to move on to our second speaker, Dr. Zhenlong Li, Associate Professor of Geography and Director of the Geoinformation and Big Data Research Laboratory at Penn State University. His presentation is titled Using Place Visitation Big Data to Improve Health Measure Estimation at the Census Tract Level. With that, Dr. Li, I'll hand it over to you.
Thank you, John, for the introduction. Let me share my screen now. Let me see, make sure I can see everyone. All right. Thank you, everyone, for joining us. And also, I want to thank for the invitation by the SBE CCC and also the funding that we received to support this work, which is impossible without that. And the topic I'm going to share with everyone today is using place visitation big data to improve the health measure estimation at the tract level. And I'm from Penn State Geography, which is the presentation might be a little bit different from the other two speakers, focusing on geography and spatial analysis and big data. This is a project team that for this project, we have two co-PIs from University of South Carolina as Dr. Shan Qiao and Dr. Xiaoming Li, which are also the members of this consortium here. And also we have, I have two students working on this project and also one postdoc that, also help here. And this is the project team, and I really want to thank everyone for the hard work in this team here. And before that, I want to share just one, I think, a beautiful map here. I want to ask you to think about just several seconds to what this map is about. If you can just look at, first, I think you know the location, right? This is for the state of South Carolina, this area. And this map it's not a fireworks, right? I heard someone usually ask this question to, oh, this looks like fireworks, but it's not. This is a visualization of over 1 million visitation flows from the home block group, the census, geography unit here to over 3,000 fast food restaurants in South Carolina in January for 1 month. This is just a demonstration visualization here. The flows are extracted from the mobile location data, which is the data we used for this study here today. And this is the entire, if you look at this is another map showing all the restaurant, fast food restaurant in the US here, included in the data. Think about for each restaurant, for each state, we can create a map like that. And for the entire US here, you might see something like a map like this. So this is, again, it's only for visualization purpose here. It's not including the entire data, but this give you a sense of the big nature of the data here, which is super huge. And we have billions of flows, basically, if you consider all this vegetation here from each block group, the place of interest, like the fast food restaurant, and also other kind of places like the gyms, parks, superstores, supermarket, and so all these kind of places that we call it place of interest or POI, that we have this kind of flow data included there. Overall, I will give you more information about data here that we processed. So this data is originally obtained from the SafeGraph, which is a data company that aggregates this location data from the mobile devices, like a cell phone that we are using. We process data for, they have about over 5 million places. You can think about component of interest, and I said, all the restaurant, including the hospitals, hospital and gyms, parks, all those are included there. So there are about 5 million places, and the data are aggregated from about 7.5% of mobile devices based on our analysis. Also, it has a high correlation with the US census population data. So, and the data contain information like place name, address, latitude, longitude, category, place brand association, daily number of visitors, and also the visitor home sensor block group, which is a very important information that we use in this study here. So this is just a brief overview of the data. So the research question we are trying to address here, as I think already shown in the title, is we want to first look at examine whether the resident routine activity information, which we can extract them from the place visitation big data, can help us to improve the health measure estimation in the small areas. For example, the sensor tract that we use in the study. So if yes here, so to what extent does the performance improvement vary between rural and urban area? We want to look at urban-rural differences, if there are any. And so traditionally, if we think about the health measure that we got this data from the CDC, we have 22 health measure, which I'm going to talk about that later. And then traditionally, we will think that those health measure, we can use the pseudo-determinant health to explain those. If you want to build a model, you can use this. Okay, we have this at the track level, we have pseudo-determinant health variables, and then we can try to build a model to see how much variance of those variables can explain the variation of the health measures, like the obesity, depression, for example. So the question here is that whether we can, if we add this place visitation big data or this information that we extracted from this big data here can better improve this model explanation power. So that's the key research question that we want to take a look here. So the methodology here is, I think it's very straightforward, and we just use hierarchical regressions. So first we try to compute the R-square of the regression using the pseudo-determinant health variable, SDOH variables, and then to try to predict or to explain these health measures at the tract level for the entire US, and also we look at urban and rural areas differently. So we get R-square, like the model fit here, and then we, in the second model, we try to look at R-square of the regression by including another kind of variable here, which is place visitation big data. So we extract the different visitation information, like visitation to the fast food, visitation to gyms, parks, and other. We have 120 categories that included in the place categories included in the model, and then we look at this another R-square, this one, which is whether this R-square, this new R-square here, is improved compared to the original one. So we do have our simple formula here to calculate the improvement. And so this is overall methodology that we are going to take here, that we took here. And so how to extract this place visitation flows from the data here. So just to give you an overall sense here, a basic sense about the data we are going to use here. We use here is 2019 for the entire US here and at the tract level. So we extracted the place visitation flows from the visitation data, and basically for each tract and to each place category, you can think about tract here in neighborhood, for example, neighborhood A or tract B, and then to each place category like pharmacy or fitness centers or fast food restaurant. And then we look at calculate the visitor per capita here for each tract. So this is the number of tracts we have here, and we have 120 number of places, place categories here. So basically we build a large matrix here, like a large table that we are going to use this to link this to other data set, then that will be used for the model. And so this place health measure data, we extract them from the places. As you can see, again, we are still using the same geography unit sensor tract, so we can link the data with the mobility data. And then we have 22 health measure that we extracted from place. Again, we are using the 2019 data. So, and now you can see that we have another kind of a big table here, right? So this is another variable. We're going, another 22 variables, which is, you can think the health measure, health outcome we're going to use here as the dependent variable in our regression analysis. So we also extracted data, social determinant of health variables from the ACS 5-year estimation, again, using 2019, same as the same level, tract level, and all this variable that we use. We use 12 here in the analysis. And so finally, we have this urban-rural classification, since we are going to look at urban-rural differences for the model. And so the data, again, we use the tract level rural urban commuting area code, that's which is derived from the USDA Economic Research Service. So we categorize this tract within this metropolitan areas as urban tract. So based on the code here, and then the rest of the tract, we consider that as a rural tract in this study. So this is all the data. So we link all this data together, basically at the sensor tract level for the entire US. And also we have two types of tracts, urban tracts and rural tracts. So, and then we run this model, as I mentioned before, these two models. One with one model only including the SDOH variables, and the other model including SDOH variable and also the visitation variables here. And then we look at improvement here. And what we see here overall, if we average for each health measure, we get R square, and then we average them together, we get, for the entire US here, we have 8%, more than 8% improvement in terms of R square here. And for the urban, we have, again, over 8%, like similar to the entire US. But for the rural here, we can see that we have 16% of performance improvement by including this visitation variable here. This is for the entire, like all this measure here. But if we look at a specific measure, health measure here, and also look at their specific or corresponding improvement, you can see the binge drinking for this urban tract here, for the urban areas. The binge drinking is number 1. And then this is a top 10 health measure that benefited from most from the visitation data here. Those columns here, you can see it's only this R square only using the SDOH variables that we get from sensors. And then this one is including this visitation data. And in addition to the SDOH variables, you can see the R square is increase for each of that. And then we have the performance percentage of improvement here. Binge drinking is number 1 in the urban tract, and including other visits to doctor for routine checkup, taking medicine for high blood pressure. So those are top 3 here. All right, it's 37% for the binge drinking, and the lowest top number 10 is 7.8%. So it's pretty, I think, significant increasement that you can see here. So this is for the rural urban tract. As if you look at the rural here, I mean, as I showed earlier, the rural area in general had a larger improvement. you can see that again, binge drinking is number one. Number one health measure that we can get improved by including the mutation data, and the improvement is over 50%. And then you have depression, some other wearable health measure here. You can see here. Again, for the number 10 here, obesity, even obesity here, we have over 16% of improvement. So this is a very significant improvement if you think about by including the other wearable, another level or dimension of the data here, which is bringing in more information, more useful information, actual information to improve the model explanation power in this case here. So if we further look at, how much time do I have left? I have 3 minutes left. Okay. If you look at the specific, since we have 120 place category, right? So we also look at which category, which places, which are actually contribute more for this binge drinking here. If we zoom into the binge drinking, what you can see here, at the bottom here is the largest, the most important, you can think of variables contributing to this improvement here. So the drinking place or the alcoholic beverage places are the number one significant places that contributing to this binge drinking improvement. I think that makes sense here. You can see also there gas line stations with convenience store is number 2 here. This is for the urban. And then if you look at the rural here, again, we see the binge drinking. The drinking places, it also shows number 1 important features or important place categories here. But the second one become a college, university, and professional schools, which is very interesting to me here. So this is the binge drinking here. And so some quick summary here. So what based on the initial result here, we can see the routine activity information, if we extract it from place weightation big data, does improve the model explanation power for the health measure estimation at this track level that we tested. And also we see the rural-urban differences. Rural areas seems to be benefit more from this mobility data in terms of measuring the health outcomes, and also the binge drinking, the specific activity, the health risk behavior like linked to the specific activity like the binge drinking benefit more because those one you can think about linking to this actual visitation, like you go to the drinking place, right? This can be easily captured in this kind of behavior, and then that this kind of measurement is you get a higher benefit when you using this data here. And also the visitation data can be a valuable supplementary data source in addition to the traditional SDOH factors for the health measure estimation. So also this study offers some new insight into the association between the place visitation and also the health measure estimation here, as you can see from the importance for the features and the connection between the binge drinking and also the visitation to the drinking places. All right, I think that's all I have here. Thank you.
Thanks so much, Dr. Lee. And with that, we're going to move on quickly to our last speakers. Finally, we're going to hear from Dr. Rob Smith, Professor of Sociology, Immigration Studies, and Public Affairs at the City University of New York, along with Andres Becerra-Reyes, PhD candidate in Political Science at the City University of New York. And they will be presenting location, how impacts of the pandemic for immigrants varied by place. And with that, Rob and Andres, I will turn it over to you.
Great. Thank you, John and Megan, and thank you to the COVID Coordinating Center, SBE, for funding the project. We are today presenting the results from the project that the Coordinating Center funded and another one that gives us more analytical leverage. So it will be myself in the first half, and then Andres Becerra-Reyes, a soon-to-be former doctoral student of mine, in the second half. So, and the opening picture is me in a protest for funding for migrant organizations in the pre-vaccine phase of the pandemic. You wouldn't know it was me, but I do like the picture. So we start our project or our presentation with a huge puzzle. So we did a study in upstate with early child care, working with parents, many undocumented, and in 23, 24, and we did another study from 2020 until the present, mostly in between 2020 and 2023, with a group in New York City, a nonprofit. And we got dramatically different results about the impacts of the pandemic on undocumented workers, particularly in the two places. In the city, they lost almost 70% of their income, from $500 a week before the pandemic to $146 in 2020 per week to only $240 per week in 2022, when most other sectors had come back. Zero savings by July. 38% of the people in 2020 had COVID symptoms, and many of the cases we developed long-term had long COVID. 75% of the people in 2020 were at risk for homelessness or feared soon being so, and 10% of the people had lost a family member already to COVID. They were in the epicenter in New York. Versus in upstate New York, there was almost no income loss among any of the workers, documented or undocumented, almost no food or housing insecurity, in dramatic contradistinction to in New York City, and few got COVID, and they got it later and less severely, and almost nobody had debilitating COVID. So this is the initial puzzle. These are imperfectly suited projects, but they give us empirical and theoretical, or imperfectly matched projects, but they give us empirical and theoretical leverage to ask and answer new questions about the impacts of COVID. And this is a very brief summary. We have a huge survey in 2020 and smaller ones in 21 and 22, 35 interviews, 3 years of field work in upstate. We did 150 surveys, 90 participants in focus groups, 15 interviews. And our model, we are theorizing that legal status interacted differently with COVID, with the pandemic, and had different impacts. Legal status and place interacted differently upstate and downstate to magnify or diminish the impacts of COVID. And we have a two-part argument. I think Tufte's using this slide as in the do not do this chapter of PowerPoint presentations. So, but we've got 4 theoretical conversations going on here. One of them is about pandemic studies, which broadly showed that minorities, the poor, and immigrants were more hurt, but very few looked at legal status. And those that don't discuss how legal status is activated. They just look at aggregates. So they do lumping, not splitting. But even people that had findings similar to ours did not sort of illuminate or try to explicate why things differed and the impacts differed in rural and urban places. A second is this, and the third have to do with legal status being a huge determinant of social determinant of health. As we know, if your parents are undocumented, they don't take you to the doctor as much, and your own toxic stress is higher, and you get excluded from many institutions, which we are going to talk about. And this paper also contributes to research on immigration federalism because it talks about the impacts of the New York State $2.1 billion excluded workers fund. And our research is showing, first of all, that documented and undocumented immigrants were affected extremely differently in the pandemic, with the undocumented being harmed more, that non-policy aspects of place and location, especially economic sectors, interacted with legal status to affect the impacts of the pandemic, and that in New York City, the legal status was activated by federal institutional exclusion as well as individual level fears, being a public charge or your data being shared, and it led people not to access help in terms of health care and the excluded workers fund. In upstate, legal status exclusion institutionally did not get activated, but the key site for the activation of legal status in their lives of driving, of racially profiled pullovers, got activated, but much less so than before the pandemic. And then we talk about the excluded workers fund. Okay, so this is the key slide in the presentation in terms of what our argument is. I'm going to walk us through. You guys can see my cursor, right? Excellent. Okay. So we start off in the pandemic with the very cruel structural exclusion from the safety net and pandemic relief programs of all undocumented workers. Even though they pay taxes and they pay in, they were not eligible for unemployment insurance. And in fact, people who lived with an undocumented person who paid taxes with an ITIN, a tax ID number, those U.S. citizen children were excluded from the CARES Act, right? Thank you. Yeah, it was a cruel exclusion. So downstate, where most of the people lost about 70% of their income in the first year, it led to massive income and job loss. The pandemic did. Exclusion from public safety net programs. It led to widespread housing and food insecurity. And legal status was activated both with this institutional exclusion and an individual fears of being deported, of how much it will cost me, of being labeled a public charge and being disqualified later from the possibility of gaining status. And it was partly remedied, this widespread impact, by the Excluded Workers Fund, which was meant to replace federal unemployment insurance for 1 year. Okay, so we are now at 6 or 7 minutes or something like that. So 7 minutes. All right. So this next one, I just told you everything that was important about this slide. So I'm going to skip this slide and go to the next one. U.S. citizens or legal status protected, U.S. citizenship or legal status protected against harms. And New York State sought to remedy those harms. So U.S. citizens and documented immigrants or undocumented immigrants with adult U.S. citizen children or spouses did not experience the same absolute deprivation because someone in the house received some sort of pandemic support. A lot of DACAs had worked in offices and worked remotely. So some of the undocumented people in our sample were insulated, as well as people who were undocumented and got legal status, got the Excluded Workers Fund. Now, the Excluded Workers Fund was also the biggest cash transfer program perhaps in the country's history because it gave $15,600 to 99% of the recipients in one shot. We identified 5 causal sequences of harm based on this absolute deprivation, followed by food and housing insecurity. One was dangerous work and long COVID. People, especially in the pre-vaccine phase, took dangerous work conditions, got COVID infections, and many of them had long COVID that persisted for 2 or 3 years that we followed them. Others had increased vulnerability of sexual harassment or anti-immigrant or of stolen wages. Stolen wages in the organization we work with increased 33% the claims during the pandemic. And there's currently in New York State $130 million worth of claims pending. There were many children who had experienced harms because they moved houses repeatedly. They were doing school remotely. People who had pre-existing conditions especially experienced accumulated health debts. Finally, weakened social networks, because social networks are posited in the literature to be protective, but they require reciprocity. So when you borrow money or when you help someone, you've got to pay it back and reciprocate. And when all the networks were exhausted, it was harder to do that. I'm now going to hand the baton over to Andres to explicate the processes within our cases. And I'm going to caddy for Andres in the remainder of the talk.
All right, thank you for the handover, Rob, and thanks for the invitation to present our work. I'm going to present some of the cases that are part of our study and which we found that best illustrate the causal sequences of harm that Rob just explained and that flesh out our larger argument. They're not the only cases that we've done. We've just picked some to illustrate the argument. I'll use pseudonyms in all cases, so none of these are their actual names. So first off, in downstate, Veronica and Maurice show us kind of the worst case scenario of place-based harms and structural and individual legal status activation. Veronica and Maurice are a couple of long-term undocumented immigrants who both work in constructions in slightly different jobs in constructions. They used to make $500 per week, but when the pandemic hit, their income was slashed to $250 per week. So they lost 50% of their income. And unlike US citizens, they didn't receive a federal program that helped them compensate for their loss of income. So they were suddenly forced to take whatever job that they could find in order to keep afloat in New York City. They found and they found jobs that were much more dangerous than the jobs that you used to do, and that received less compensation. In their jobs, they both contracted COVID that would then develop into severe symptoms, and they reported symptoms that lasted onto 2021 and 2022. Because of their fatigue and because of the relative lack of work, they were unable to find a job that compensated for their lack of income. They couldn't pay rent. They faced housing insecurity, and they started moving from house to house. And they eventually ended up in a single room in a property, in a house that was occupied by up to 19 people at a certain point with only one bathroom. So there was severe overcrowding after having lived in an apartment on their own. The downstream impacts of the COVID-19 pandemic was that none of them sought medical care, both Veronica and none of them applied for the Excluded Workers Fund. They both feared that seeking medical care would activate their legal status, their lack of legal status, and that applying for the Excluded Workers Fund would similarly put them in a vulnerable position. When they did eventually apply to the Excluded Workers Fund, it was out of funds, so it no longer made sense for them to apply. In the long term, Veronica and Maurice, in the last interview that we conducted with them, they still lack savings. Their daughter is behind in school. They still report feeling sick and having fatigue. They can't pay back rent. They can't pay back loans for their relatives that they own, and their migrant networks are severely under strain. The next case, please. The next case is a case also in New York City, also by a long-term undocumented immigrant called Jessica. She used to clean offices in New York City, in Manhattan, but when the pandemic hit, her income suddenly became zero. And again, because she didn't have any support from the federal government or from other forms of other government, she found a job. She looked desperately for a job. She found a job cleaning a hospital at the height of the pandemic. That job clearly didn't provide proper PPE. She was part of a crew of other undocumented Latinx immigrants who were cleaning a hospital. She got COVID very quickly. And her story is similar to Maurice and Veronica's, with the exception that her landlord didn't kick her out and didn't pressure her to pay rent, understanding that she couldn't pay it at the time. Her income was down to zero for several months during 2020. She again subsisted with loans and food that her family provided. And unlike Veronica and Maurice, she did apply to the Excluded Workers Fund, and she did receive a $15,600 cash transfer from New York State, in 2021. And although she considered the Excluded Workers Fund a godsend, it was barely enough to pay back the multiple loans that she owed, including some of the back rent, which she couldn't complete the whole of the back rent that she owed. And she also used the money to obtain urgent medical care, especially in dentistry, because of inflamed gums that she had suffered. In her latest interview, she reports that she can still only work 4 hours a day, so she still makes far less than what she did during the pandemic, about 50% less. She hasn't recovered from pre-pandemic. The next slide, please. So essentially, downstate is legal status is activated more severely, especially through the economic sectors that most undocumented immigrants participate in. Upstate, the economic sectors were more resilient to the pandemic. There wasn't a kind of immediate and sudden loss of jobs, but it is activated through driving. The next slide, please. So in the first case, driving is a site of activation, but it actually doesn't cause more harm. And this is the case of Allison, an agricultural undocumented worker who regularly drives to work. She's regularly stopped by the police and is sometimes extra ticketed for things that clearly for infractions that clearly she didn't commit, but she doesn't complain about that, as a lot of undocumented immigrants don't, because of fear of confronting the police or going to court. So she just pays the extra tickets. She got a letter from her employer stating that she was an essential worker during the pandemic. And when she was stopped by the police, she showed the letter and she was not ticketed. And not only that, she was also at one point thanked by a police officer for the work that she did. The next slide, please. However, in other cases, driving was a site of activation of legal status, and it worsened the effects of the pandemic. In the case of Daniel and Gabi, Daniel is an undocumented immigrant who was deported from upstate New York once he was pulled over. He went back to the United States, crossed the border again to reunite with his family. Gabi, his wife, became very ill with COVID-19 when she was 8 months pregnant, but Daniel was too scared to drive her to the clinic, so waited until she became very, very ill and had, kind of life-threatening symptoms, and then he drove her to the clinic. She and the newborn baby would eventually spend 3 months in the hospital, and she had long-lasting symptoms, including extreme fatigue and depression, which meant that she couldn't go back to work, and the family income suffered greatly. So those are four cases that illustrate some of the mechanisms that we found and the broader argument that we're advancing around how location and legal status interacted during the COVID-19 pandemic. There's much more to the paper that we'd be happy to talk about later on. Thank you very much.
Perfect. Well, thank you, both Rob and Andres, and the rest of our speakers. And again, I'm just impressed at how much you guys were able to fit into relatively short presentations of just 15 minutes. We do have about 5 minutes for questions. So I want to open it up to the floor. You can go ahead and feel free to just unmute yourself, or if you'd rather type something in the chat, that works just as well.
I guess everything was entirely clear among all three presentations. I've never seen that before.
Well, I guess I can start with Julie. I know you were talking about seeking some additional funding to kind of expand on some of the work. Are there additional considerations? Are there additional things that as we have kind of moved out of the first years of the pandemic into kind of this quasi, where it hasn't quite transitioned to, being endemic, but we're clearly in a different stage in 2020, 2021. I'm just curious, how that might change your thinking as you expand your study.
That's such a good question. It's been tough, right? As you're trying to the speed of the research and everything takes so long to get approvals, and then before you know it, your CBOs are like, "Oh yeah, this is no longer a concern of ours," and it's like pulling teeth to get them to to collaborate, right? Not, that's maybe an overstatement. It's tough. I would probably look into a more general vaccine hesitancy scale, and including a couple of questions about COVID, because I do want to continue tracking that among refugees over time, but probably generalizing that scale and looking more at just that general vaccine hesitancy scale, which has been translated and validated in a number of languages.
Gotcha. Thanks. It looks like we have a question, Rob. I think Andres just barely beat you. So we have a question from Andres in the chat about whether vaccine hesitancy varied by national origin.
We are just scratching the surface on that. With our quant analysis, we started by just examining health literacy and potential differences by national origin there. We just kind of started that. And then next step is looking at vaccine hesitancy by national origin. So I don't know. Jury's out. We don't know yet, but it'll be really fascinating to see if there are differences.
Rob, I saw you had your hand up.
Yeah, Julie, I think your study is really super interesting. I think with the interviews, you have a chance to illuminate the processes by which vaccine trust is generated, right? So I like the frequencies and I like the theme, but I think a process tracing approach that you could draw out from the interviews, this is where the person started and this is how the person ended up with more or less trust, would be super interesting and a huge contribution, and it would be portable, because I hope I'm wrong, but my guess is we're probably going to have another epidemic at some point. If you wanted to chat about ways to do that through the interviews, I'm more than happy to chat with you. I think it's interesting and useful work. So
thank you, Rob. I'm such a big fan of your work, Mexican New York. It inspired my study back in grad school on transnational dairy workers from Mexico to the upper Midwest, and new destination scholarship. I kept thinking about that as I was listening to your and Andres's talk. But that's a great, some of it is the focus group data, right? It's like focus groups are different from what you all are getting in those in-depth interviews where you're tracing somebody's story and you got that whole hour with them or whatever. But the focus group is so hard because you just get kind of insights here and there on the general topic.
Let's talk offline.
That would be
offline
great.
from this context. I think there's ways you can do it. It's not as good, but I think there are ways that you can take advantage of that.
Totally.
I'm happy
Thank
to
you.
think it through with you. It's interesting work you're doing. I'd love to support it.
Thank you so much, Rob. Thanks a lot. And thanks for you and Andres' talk. It's fabulous.
I want to thank again all of you guys for joining us. I want to thank each of our three groups of speakers for sharing the really great and interesting work that you're doing. And yeah, we're really happy to have you guys be a part of this consortium and hope you will continue to be active participants. And so with that, we wish you all the best and
Thank
stay
you,
warm.
everybody.